Hello, class, and welcome to Diverse Populations. This week we're going to be exploring a little bit of doing culturally responsive assessments in addictions counseling. My name is Dr. Neil Soggie, and I will be your instructor for this course. So, when we talk about assessments, this is something that often is one of the first encounters a client has with the helping system. It really sets the tone. It shapes the treatment plan. It informs eligibility for services and insurance billing and case conferencing and sometimes legal outcomes. But assessment is never neutral. Every question we ask, every form we use, every symptom we identify is shaped by cultural assumptions, both our own and those built into the tools we rely on. Now, what happens when a client from a collectivist culture hesitates to speak openly in an individual intake session? How do we interpret that? Do we interpret that as resistance, for example? What happens when a grieving Indigenous person speaks to their ancestor and we mistake that for hallucinations? What happens when we assign Western labels like major depressive disorder or borderline personality disorder to someone whose distress is actually rooted in intergenerational trauma and displacement or cultural suppression? For many decades, research has shown that clients from marginalized communities, whether that be Indigenous or Black or Latina or Asian or LGBTQ plus, Two-Spirit clients, are more likely to receive a less accurate assessment. Now, I want to kind of clarify a little bit here that we're not really diagnosing in addictions counseling, but we are kind of trying to assess and identify what focuses of treatment might need to be. So I want to just kind of clarify that a little bit. Diagnosis of mental disorders normally reserved for like a psychologist. And we're not licensed to do that as addictions counselors, but that's not our role. Our role is to kind of get a lay of the land and develop a plan based upon the client's goals. Now, something that we're going to do within this lecture is to explore a little bit of the cultural formulation interview, and which is part of the DSM-5 TR, and to help kind of guide our culturally informed assessment. Now, as we move into this week's topic, which is essentially culturally responsive assessments, and sometimes I will slip up and use the language of a diagnosis, and I hope you just kind of are mindful of that. One of the first things we're going to do is I want to tell you a little story about someone, as I always do. But then I want to focus upon three themes that hopefully will honor people's full humanity, including their cultural, historical, and spiritual realities. The first thing I want to kind of touch on as themes for this lecture is the cultural formulation interview, which is introduced in the DSM-5 and expanded in the DSM-5 TR, which is something that you can purchase at the bookstore. This tool was developed to support clinicians in gathering culturally relevant information during assessment. But the cultural formulation interview is more than just a checklist. It's an invitation to cultural humility, and hopefully helps us as clinicians to define problems, to understand belief structures, to understand how and why people are turning for help and their cultural background that shapes their understanding of suffering and healing. The second theme I want to focus on is some of the risks of misdiagnosis during cultural misunderstandings. So we'll examine things like racial bias and unfamiliarity with cultural norms and language barriers and unexamined clinical assumptions that have historically led to an overdiagnosis in some communities and an underdiagnosis in others. So, for instance, Indigenous clients are frequently misdiagnosed with schizophrenia or psychotic disorder due to spiritual beliefs, while Latin and Black clients are more likely to be diagnosed with behavioral or conduct disorders than with trauma or depression. And so we'll explore some of the real-world examples of how cultural misdiagnosis happens. And our third and final theme is about integrating cultural knowledge into intake and diagnosis. So we'll discuss how to move beyond the surface of cultural awareness and build assessments that reflect real cultural understanding. So this is going to include making space for traditional beliefs, understanding how social and historical trauma shows up in clinical symptoms, and co-creating assessments with clients that respect their own knowledge systems. So really, it's about strengthening clinical accuracy while also building relationships of dignity and trust and respect. Now, to understand how the fields of psychiatry and counseling and addiction studies began to seriously grapple with culture, not as just some kind of background variable, but as a central determinant of mental health, I want to look at the work of a key thinker and advocate, Dr. Lawrence Kiermaier. Kiermaier is a Canadian psychiatrist. He's a medical anthropologist and a researcher whose career has really been defined by one persistent question. How do we understand mental health and illness in ways that genuinely respect and reflect cultural realities, particularly those of Indigenous and marginalized communities? Now, Kiermaier is kind of one of those cross-border people. He was born in the United States in 1954 and then later moved to Montreal, Quebec, where he spent several decades working at that kind of intersection between culture and trauma and psychiatry, and particularly in Indigenous mental health. And he's currently the director of the Division of Social and Transcultural Psychology at McGill University, which is kind of like the Canadian version of Harvard, and has served as the editor-in-chief of Transcultural Psychiatry. And Kiermaier, as far as his role, is really, he was focused on shaping how clinicians assess and diagnose psychological distress. So very early on, Kiermaier saw firsthand how psychiatric models often misread or just completely ignored cultural meaning systems, particularly those of Indigenous clients in northern Canada, as well as immigrant communities. And symptoms were interpreted through a Western lens, and that appeared to be leading to clients not being treated as best that they could. And so he was one of the leading architects of the cultural formulation interview that was first introduced in the DSM-4 and then significantly expanded in the DSM-5 and the DSM-5-TR. And so this tool was revolutionary because it recognized that accurate assessment depends not only on what symptoms a person has, but on how they understand those symptoms and how those symptoms function within their culture, and how cultural identity and migration and colonialism and racism shape mental health experiences. And Kiermaier has consistently argued that culture isn't something that's static or superficial. It's not about memorizing a set of facts about someone's ethnic background. Instead, he wants clinicians to be aware that culture is something that is fluid, it's contested, and it is lived. And so part of the clinician's job is to engage in what he calls collaborative interpretation with their clients, rather than simply imposing a clinical narrative from above. So it's about understanding the lived world that the client lives in so that you can honor the client and the client's understanding. So, for example, Kiermaier worked with the Innu and Inuit communities in northern Canada, where spiritual experience such as communication with ancestors were routinely misdiagnosed as delusional. And rather than kind of impose that kind of understanding, he argued for understanding distress that takes seriously indigenous epistemologies, that is the source and foundation of knowledge, and recognizing that what may appear pathological in one worldview is sacred or normative in another worldview. And so he has not only informed Canadian policy, but has shaped the World Health Organization's guidelines for culturally appropriate mental health care. And so this has impacted training programs for psychologists and addictions counselors around the world, not just in North America. So today, Kiermaier continues to teach and write. And some of the things that he kind of pushes for is, rather than asking what is wrong with this person, ask what has happened to this person. And how do they make sense of it, culturally and historically? And I hope you see there how this becomes an ethical necessity. So, if you ever want to take a little bit of time, actually, part of your readings for this week include the cultural formulation interview. So I do encourage you to take a little bit of time and look at Kiermaier's work. Now, in many ways, the clinical intake interview is that first moment where a counselor begins to see a client, not only in terms of their distress, but as a full human being. But how we see is shaped by how we ask. And for too long, mental health assessments in North America have been conducted in ways that centered on Western, middle-class, really white, individualistic frameworks, often at the expense of cultural accuracy or relational nuance and collective and spiritual identities. And so, hopefully, understanding the cultural formulation interview gives you a little bit of background for working through that. Now, there are some basic domains that I want you to kind of be aware of. And really, the full cultural formulation interview is really kind of 16 question interview questions that are organized around a number of domains. The first one is, how does this culture define the problem? The second one is, what are the cultural perceptions of cause and context and support? The third question is, what are the cultural factors affecting self-coping and past help-seeking behavior? And finally, what are the cultural factors affecting the current help-seeking behavior? So suppose you're working for a very traditional Dakota client. They come into your office after relapse, and instead of jumping to questions about how many days they've been using or which substances are involved, you begin with the cultural formulation interview. You ask, can you help me understand what the problem is from your perspective? They tell you that they feel like their life doesn't have a center anymore. They say their grandfather, who used to pray for them, passed last winter. They stopped going to ceremony. They're not sure if their spirit is with them anymore. Now, to some clinicians, that might sound pretty vague, some weird spiritual statements, and they're not really relevant. But for someone that's trained in the cultural formulation interview, they are critically and clinically vital. There's a expression there of spiritual dislocation. There's an expression there of grief. There's an expression there of cultural rupture. And all of those can be tightly linked to addiction relapse, particularly in Indigenous communities. So I want you to just kind of be mindful of that. Things like kinship, things like spiritual mentorship and ceremonial participation become very, very important in working with clients. And so the cultural formulation interview can help to get a more accurate understanding of the lived world of the client. That's something I like to kind of push, the idea of the lived world. Part of our job as clinicians is to enter into the lived world, and by that I mean the world that makes sense for the client, and understand and explore their world. Now, we can have different understandings, and that's fine. But until we engage their world will not be changed. And it's really their world that they have to live in. So we're not helping them until we help them understand their lived world and help them to find healing within that lived world. So, as we deepen our understanding of culturally responsive assessment, we really need to kind of confront a harsh truth. We're all, anybody that has grown up in America is immersed in Western views. And inevitably, if you're studying counseling or psychology, this is going to bleed into your understanding and can lead to basic errors because we're looking at a client through a particular lens. Remember, diagnosis and assessment is never neutral. The questions we ask, the symptoms we emphasize, the categories we use to organize distress are all shaped by our cultural experiences. And if that lens is limited, or worse, unaware of our own biases, then we end up doing a disservice to our client by mistaking difference for disorder. And there's a very big difference between those two. Now, the problem here is that we need to recognize that a misdiagnosis on this kind of basis is not just a clinical error. It's really kind of a form of structural violence. And it reflects a system that centers one cultural reality as normal and treats others as deviations to be corrected. So, for counselors working in addiction and mental health, especially in multicultural or Indigenous serving settings, the risk of misdiagnosis must be taken very, very seriously. A client's diagnosis shapes really everything: their treatment, their identity, their self-understanding. So when we get it wrong, when we pathologize culture, we not only harm the individual, we also reproduce the very systems of oppression that many of our clients are trying to heal from. So, something that we can do is really just listen differently. When a client shares a story that doesn't fit easily into clinical categories, let us pause and ask things like, what might this mean in their culture? How might I consult to understand this better? Am I interpreting this experience through my own cultural bias, or am I open to another framework? So we need to commit to lifelong cultural learning, not one that says, I am the expert and know everything. None of us know everything. We all have to live with some cultural bias. There's a good Greek saying, a Greek term called epoche. Epoche basically means walk into a situation without knowing. Be open and let the experience guide you. That is good cultural humility, to let the experience guide you. Let the client's lived world inform your understanding of them and how they are dealing with the problem. And with that, then you can kind of move forward and co-create with the client how to best approach a recovery plan. So if cultural misdiagnosis is a form of harm, then logically, incorporating cultural knowledge into assessment should be a form of healing. And it is that, but it's also a clinical skill. It's one that really needs to be practiced and refined and continually deepened over the course of a counselor's career. The intake process, especially in addiction and mental health treatment, is not just about gathering data. It's about developing therapeutic rapport. It's about building a relationship. And the first time a client may be able to actually describe their suffering out loud. So we need to be open to how they do that and not demand that they shape their description around our Western assumptions about what's real and what counts as part of the problem. So when you do your intake, it's more than just asking a few questions about ethnicity or religion. It means starting from a different posture entirely. Being open, being humble, being willing to co-create and co-understand and interpret the client's experience. Cultural knowledge is about how we interpret what we hear, yes. If the client says, I started drinking more after my mom died, and I felt like I lost my way. I couldn't go to ceremonies without her. So a culturally responsive counselor doesn't simply say alcohol use that was triggered by grief. Instead, they hear the cultural dislocation. They hear the spiritual longing, perhaps a call to return to sacred relationships. That kind of information becomes clinically central, not just context. And so the counselor can help the client to move towards finding a better place in their community. Now, need to remember, counselors need to avoid appropriating or mimicking cultural practices that don't belong to them. But this also means we remain silent or that it doesn't mean that we remain silent or uninvolved. Rather, we can act as cultural allies, professionals who use our role to make space for Indigenous and community-based knowledge systems, not dominate or replace them. It's about being collaborative. It's about bringing in traditional healers or elders or cultural mentors, or encouraging the client to have that as part of their homework, to visit with and learn from cultural mentors. It's about adjusting assessment tools. It's about being mindful of historical losses and language suppression and boarding school experiences and racism. It's about understanding and recognizing the importance of nonverbal expression and culturally specific communication styles. Being culturally responsive in our assessments doesn't mean abandoning clinical standards. It means expanding them. It means recognizing that healing happens through many paths, and our job is to help clients walk their own path with support and respect. Now, what happens when culture is ignored during the intake and diagnosis process? What's lost when we treat the assessment process as being, purely neutral and clinical and objective rather than a relational and cultural encounter? The answer to that is really both sad and simple and devastating. When cultural meaning is left out, misunderstanding becomes institutionalized, and clients are often left carrying a diagnosis that doesn't reflect who they are or what they're actually experiencing. So, addictions counselors need to be mindful of context. And be mindful that without context, we are damaging the relationship. Treatment plans are often built on initial assessments. And if the assessment is inaccurate or culturally misaligned, the entire plan will be built on very shaky ground. Hope that makes sense. A person who pushed towards medication when what they need is ritual can obviously be dysfunctional. They may be referred to anger management when what they need is grief work. They may be offered behavioral interventions when what they need is someone to walk with them back to their own community. When we ignore culture, we're not being objective, we're being incomplete. And in that incompleteness, the client is asked to leave parts of themselves outside the room. That is not healing. That is disconnection. That is fragmentation. A culturally responsive counselor works differently. They begin by listening, not just to what the client says, but how they say it and what cultural frameworks are embedded in their language. They avoid rushing to a label. They ask about family and history and community and ancestors and spirit. They check their own assumptions, knowing that their Western framework is not universal. And they see the intake not as a moment for diagnosis, but the beginning of a relationship of respect, of building therapeutic rapport, of co-exploring the client's lived world. When we shift to being culturally open, something shifts in the whole process. Diagnosis doesn't become a label, it becomes a shared understanding. And the client doesn't feel judged or reduced or pathologized, they feel seen. And that feeling of being seen is often the very first moment of healing. So I want to kind of just touch on a few guiding principles that, when remembered, can prevent harm and restore trust and ultimately make you a better counselor. The first is explanatory models. Now, this is a term that was first popularized by medical anthropologist Arthur Kleinman and later integrated into psychiatric practice through tools like the cultural formulation interview. But at its heart, the explanatory model asks a simple but very profound question. How does the client understand what is happening to them? And this matters because human beings do not experience distress in a vacuum. We all interpret our pain through story and culture and language and history and spirituality. So, a person raised in a Dakota community may describe grief not as a psychological state, but as a place of being out of spiritual balance, out of step with ceremony, or disconnected from ancestors. A Sami client might interpret depression as the loss of connection to land or the silence of ancestral songs. Now, if we fail to ask how a client makes sense of their suffering, then we run the risk of treating the wrong problem, or worse, treating the person as the problem. The second concept I want to get you to think about is the cultural context of in symptom expression. So, not all symptoms look the same across cultures. In fact, many cultures have entirely different ways of showing or hiding or managing emotional stress. For example, some clients may express trauma through somatic complaints. Had some students from China, for instance, that had chronic pain and fatigue and digestive distress. This was a cultural expression of emotional distress, but it was somatic complaints. Others might speak in metaphor or story. Others may use ancestral language to describe it. All of these are ways that the client is trying to translate their experience. They don't know clinical language. So we need to take some time and understand what it is that they mean and how they are understanding their experiences. The third concept is the whole idea of collaborative meaning making. Assessment should not be something done to the client. It should be something created with them. And this is perhaps the most important shift in culturally responsive practice, from extraction to relationship. The counselor doesn't sit in the expert's chair while the client is expected to perform self-disclosure. Instead, the process becomes a conversation grounded in trust and cultural humility. These are foundational practices. Using explanatory models and exploring that, and finding the cultural context and collaborative meaning making. These are things that help us to walk ethically and effectively with diverse clients. So, imagine it's a rainy Monday morning and you've just started your shift at a community behavioral health center that serves a wide range of clients, including urban Indigenous youth and adults referred from tribal court programs. And one of your scheduled intakes is a young man, 20 years old, come from a local Dakota community. He's referred by probation after a recent marijuana-related charge. And they suspected they have some co-occurring depression. His file doesn't say very much, except they missed some school, lost a close family member last year, and is really unmotivated in treatment. He walks in, hood up, barely any eye contact. His posture is slouched, his voice is low. If you were assessing from a purely behavioral or symptom-based perspective, you might mark down flat affect, poor eye contact, minimal verbal communication, signs of depression or even mood disorder. But then you pause. And you know that at least historically, in Dakota and Indigenous communities, avoiding eye contact is often a sign of respect, especially in unfamiliar settings. You also remember that grief may be held in silence, and that many clients, particularly young Indigenous men, are taught not to speak openly about emotions, especially in clinical settings, especially if they've been taught, often painfully, that institutions are not safe places. So instead of jumping into the symptom checklist, you start differently. You say something like, it's good to meet you. Thanks for coming in. I know it's never easy being in a place like this. Just to be clear, I'm not here to fix you or judge you. I'd just like to hear in your own words what you want me to know. And then leave a space for a long pause. Eventually, he'll probably say something like, I've been feeling off, like I'm not really here. Now, a conventional assessment might label that disassociation or depersonalization symptoms, but you're very careful as a clinician. When you say you're not really here, can you tell me more about what that means for you, you ask. Another long pause. And then they softly say, it's like ever since my uncle died, I haven't felt like I belong anywhere. I don't feel right going to the lake. Certain places I just don't want to go to anymore. And then you learn that this young man had a relationship with his uncle, that they did things at certain spots. They would go to the lake together. They would go to do different activities together. They had a close relationship. And you listen, and it's not just about grief. It's about disconnection to culture, to land. There's a cultural and spiritual void there. And so you ask a question, and they fill in a little bit more information. This can go a long ways to informing your treatment plan that doesn't just build on clinical goals, but helps to recognize loss and cultural reconnection and the need for cultural reconnection. That is what it means to have culturally responsive assessments. Now, sometimes the most damaging mistakes in counseling doesn't come from cruelty or carelessness. It simply comes from good intentions wrapped in limited vision. They come from counselors who are doing their best, but doing it through a lens that hasn't been cleaned or questioned in years. And nowhere is that more evident than in the process of assessment. Remember, assessment is one of the first gateways of power in the helping relationship. It determines how a person's story is interpreted and labeled and documented and then ultimately treated. And it decides not just what kind of care a person will receive, but how they will be seen, often for a long time afterwards. And when cultural understanding is absent or very superficial, the result can be both clinically incorrect and personally devastating. So, always ask questions like, are there any tiny acts of mistranslation that I've marked down? So you question that. You look for, how am I understanding this client's lived world? You engage in cultural inquiry. Because some experiences are not symptoms, they are connections, and we need to kind of be mindful of that. So we need to remember that this can be basically epistemic violence, when we deny a person's way of knowing and being as valid or real. Everybody's lived world is real. It's real for them. It's the only world that they have. And we need to be mindful of that. We can help them to change their world, but we can never, or should never, discount their world. Because it is where they live. It is their home. It is their way of belonging and making meaning. Now, we've discussed many of the practical and human consequences of culturally informed assessment. How misdiagnosis and broken trust and clinical harm can all be so damaging. But I also want to look at the ethical foundation of this issue, because culturally competent diagnosis is not just a best practice, it is a professional obligation. Everybody that's trained under the American Counseling Association or the National Association for Alcoholism and Drug Abuse Counselors or other accrediting bodies are expected to understand this, to have awareness, first off, of their own cultural identities, and then to respect the cultural identities of their clients and avoid imposing their own values on others. I'll say it again. Maybe I'll quote directly from the American Counseling Association Code, Section 2A, C2A. Practice only within the boundaries of your competence, based on their education, training, supervised experience, state and national professional credentials, and appropriate professional experience. And in the midst of that, when you're working from a cultural background you're not familiar with, the standard expects and requires more than just good intentions. It means consulting with cultural experts, seeking supervision, reading, listening, learning, and documenting what you're doing in that learning. NADAC's Code of Ethics says this: addictions professionals shall develop an understanding of and shall provide services that are sensitive to the diverse cultural backgrounds of clients. The cultural formulation interview isn't just helpful, it's ethically aligned. It's how we begin the process of honoring others and caring for others. So, it's easy to think, of diagnosis is something that happens in a one-on-one setting. A client walks in, the counselor asks questions, and together they name what's going on. But in many communities, particularly Indigenous peoples and collectivist cultures, that moment of diagnosis doesn't just affect the person sitting in the room, it ripples outward. It is a collective act. Assessment carries weight of history and family and identity, and we need to be mindful of that as well. And so we can't cut the person off from community-based supports. The cultural formulation interview builds trust, but it also calls us to help the client to engage with their larger collective story. This might mean having some homework assignments that are kind of designed into the treatment plan that include things like speaking with elders, talking circles, sweat lodges, family gatherings, language programs, land-based therapy. All of those things might be helpful. It doesn't mean that we as the clinician need to do those things, but it should be part of the larger healing strategy for the client. It's about not just diagnosing a person, it's about honoring the person and honoring their story. You're including the community. You are contributing to collective healing, because the person often is the community in a very real sense. So as we bring together the teachings of this week, I hope it's clear that culturally responsive assessment is not just asking different questions. It's about holding a very different stance, one that reflects cultural humility, relational respect, and really an ethical commitment to see the full truth of a person's experience. So I want to kind of just go over again the basics of this week's lecture. So the first most important thing, be mindful of explanatory models. When a client walks into a counseling space, they're not just bringing symptoms, they're bringing a story. They've already made sense of what's happening to them, even if they haven't put it into formal words. And your role as a counselor is to honor their version of that story. Don't replace it with a diagnostic label too quickly. The question is not just, what is this? The question is, what does this mean to you? When we explore the client's explanatory model, we move from labeling to understanding. We stop being symptom checkers and become partners in meaning making. The second concept I want you to be mindful of is the cultural context in symptom expression. So when people, just remember that people show pain in different ways. In some cultures, grief is loud and public. In others, it is silent and internal. In some communities, trauma shows up through physical illness. In others, it shows up as spiritual disconnection. Without knowledge of the client's cultural background, and without curiosity, most importantly, we risk misreading the language of suffering. So interpreting normal cultural expression as signs of a disorder does the person a disservice. We need to help the person feel like they have been seen in their own skin. Like we are actually honoring them, because we are in that process. And then finally, the third is the collaborative meaning making. And here, I want you to kind of remember that in Western clinical training, the tradition has been that the counselor is often taught to be the expert. We want to unlearn that practice. We want to be well trained, of course, but we don't have all the answers. With culturally responsive assessment, that means that we're letting go of that posture and we are creating a space for shared interpretation, where the client's voice, their culture, their lived world, their spirituality, their way of knowing is at the heart of the process. You're not telling them what's wrong. You're working together to understand what's going on, why it's going on, and what healing might look like in their world. So these three concepts of explanatory models, of cultural context, and collaborative meaning making really form the foundation of ethical, responsive, and effective assessments within addictions counseling. So, here's a quiz question. A 45-year-old client from a Lakota background describes seeing visions of her deceased mother during a period of intense grief. She says these visits are comforting and occur most often after she smudges and prays. She's seeking support for alcohol use, but has no history of psychosis or disorganized thinking. As her counselor, what is the most culturally responsive action to take during assessment? In this case, I would say that it's to validate the spiritual experience and ask how it connects to her grief and healing and cultural traditions. That respects the client's spiritual worldview, their lived world, and it invites deeper meaning making, and that can be very healing in this process. So as we close out this week, I want to leave you with a thought that may stay with you longer than anything I've had in my slides, and that is this. Assessment is not a label. It's a reflection of a relationship. And when a client comes to us in pain, they're not simply bringing symptoms to be categorized. Sure, that's part of the process. But they're also bringing a life, a history, a family, a culture, a prayer. And they are offering us, in a state of great vulnerability, the chance to witness them at a threshold of change. That moment between suffering and the possibility of healing, and they're asking us to walk with them. And if we rush to label without understanding, not only do we risk misdiagnosing the person, we miss that person's truth. We miss the whole flavor of that person's lived world. To be a culturally sensitive counselor in doing assessments means to become a listener to meaning. How does this person create meaning within their life? How do they interpret their world? How do they experience their world? And in so doing, we are honoring that person. And it's only there and then that healing can truly take place in that client's lived world. Hope you enjoyed this lecture, and I will see you next week. You take care. Bye-bye.